Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world. From coast to coast, border to border, and to all the ships at sea, I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning into the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare delivery and technology. I'm very pleased today. My guest is Emily George, who is a senior consultant for Day Health Strategies. Day Health Strategies' mission is to transform the healthcare system to make it more patient-centered, affordable, and high-performing. Emily holds a bachelor's degree in nursing, a master's in public health, and is currently pursuing her doctoral degree in public health at Boston University. I'd also like to say Emily's a fellow podcaster of mine, and she hosts her own podcast, Unlocking Accountable Care, on our shared Healthcare Now radio network. Emily, welcome to the Tate Chronicles.
Thank you so much, Jim. Glad to be here.
This is really a timely area to really discuss because with your background in public health nursing, we're in the midst of a current pandemic, and the role of public health nurses and public health workers has never been more significant. From what I've seen, Emily, for many, this will be the greatest challenge of their careers as they bring their training and experience to combat the coronavirus pandemic. Those who have labored for so long in the background are now front and center in this struggle. So before we talk about the present, let's talk about the past a little bit. What has been the traditional role of public health nursing?
Sure, that's a great question. You know, it's really fascinating because nursing had its origins in public health from the very beginning. You know, Florence Nightingale's work in the mid-1800s, she was a central part of the whole nursing movement, and she was out working in the poor, developing sophisticated tools to track epidemiology of diseases. But the phrase public health nursing was really coined by Lillian Wald back in the 1890s. And she invented this term to describe the role of the nurse who understood the various problems that accompany those who live in poverty or in, you know, underserved communities. And now we call these social determinants of health now, or health-related social risk factors. And those phrases have generated a lot of buzz most recently, and it's wonderful. But really, this is an age-old concept that is fundamentally baked into the science and practice of most nurses. And to kind of just talk a little bit about what public health nurses do that kind of separates us is we don't just look at individual illness. You know, we look at all of the things around individuals that are impacting their health and well-being. And then, you know, we marry the knowledge and deep understanding of the entire population. So disease trends, environmental risks, health-related social risk factors that may be impacting the community overall. We marry that with clinical understanding of health and disease management of individuals and families. And then what it does is it really uniquely positions us to then translate those community and individual level experiences into practical implications or recommendations for health planners, policymakers, and political activists. And that knowledge translation, Jim, really goes both ways. So we also become uniquely positioned to translate policies and health education back to individuals in a way that's easy for them to understand. So I see public health nurses as one of the most powerful linkages between people serving at the highest levels of our government, academic institutions, or health systems with the people on the ground who are accessing and experiencing the health system on a daily basis.
You know, Emily, one of the things you mentioned there was the phrase political activity. And so could you go into the details of that a little bit? I think I know what you mean, but I'm not sure. What do you mean by that?
Yeah, so, you know, nurses at their core, we've always been advocates for the patient. And as this role has evolved over time, which I'm happy to describe a little bit more if it's helpful, but we take those things that we're seeing about the patient and the health system and communities, and we can really serve a pivotal role within policy and state policy, all the way up to our federal policy. And so a lot of nurses, whether people know it or not, are on the front lines of lobbying for policies that will help the population at hand that they're serving. And so again, a lot of us in our training, especially those who have gone on, past to their bachelor's, are trained in policy to really understand how can we make change at the highest level to really impact the communities that we're serving.
I don't know if this is a corollary to what you're talking about, but I've run across some articles and webinars I've been watching online since we've all been home for a couple of months now that have to do with the fact that underserved or populations without any particular voice are often populations in which there's a higher environmental risk from pollutants.
Mm-hmm.
Whether it's whether wastewater plants are built or petroleum distilleries are built or things like that. So is that kind of what you're talking about? Bringing those kind of policies out where they're hot spots?
Exactly. And so you'll see nurses and other health advocates working on environmental risk factors, the ways that, yes, access to safe water, access to clean air. This is in schools, advocating for, this can even be thinking about reducing smoking around public schools. We've seen that as a legislation that has come through. Another really interesting thing is just thinking about access to reproductive health and sexual health, sexual ed in schools. Nurses are on the front lines of advocating for those changes so that people everywhere can access the preventive care that they need to actually promote the health of their communities.
You mentioned clean water, and that reminds me of in Michigan, I don't know if it was in Detroit or Flint, where essentially an entire community was being subjected to lead poisoning because of decisions that were made, budgetary decisions that were made. And it was pediatricians and public health nurses who picked up a trumpet, started blowing the trumpet to get attention and get the media.
Exactly.
And that's what it took to get some amount of involvement by the government to start working on that. It was hard to believe that happened in the United States, but it did. And it was those healthcare workers who really brought it to everyone's attention.
Exactly. We can have a very strong and fierce presence, when we're advocating for the communities and the people we believe in.
So we've talked a little bit, Emily, about how the role has evolved over time, but it seems like what they all now call the Great Recession, 2008, 2009, that there has been a loss of public health workers. What's caused that, and how bad has it gotten, and what are the ramifications of that?
Sure. So, yeah, it's widely known in my field, and maybe not be widely known to others, but public health funding has really been slashed over the past few decades, and we really took a hit in 2008, 2009. The Trust for America's Health, which is a nonprofit devoted to promoting community health and well-being, estimates that public health efforts are about $4.5 billion underfunded. And what that really means, just to give you some context, so in 2017, the U.S. spent close to $3.5 trillion on healthcare, and only 2.5% of that was devoted to public health funding. And when we talk about public health funding, like we were just mentioning, we're talking about funds that support your local and state public health departments or other efforts, which oversee responses to disease outbreaks, surveillance, the opioid crisis, alcohol and smoking prevention, access to reproductive health care, all of the things that are actually promoting the health of communities. And so if only 2.5% of that is going towards health promotion or prevention, then we're seeing the other trillions of dollars being spent on these downstream effects of illness and disease. And so it seems like, public health nurses and other workers are always advocating to turn that on its head. An ounce of prevention is worth what, like a pound of treatment, or whatever the phrase is. If we could turn that on its head and really devote money and public health spending to build infrastructure and health promotion, we would end up saving money in the long run. And I want to just mention now a fantastic article that was written by a colleague of mine just recently in the Public Health Nursing Journal. Her name is Joyce Edmonds, and she's at Boston College. And she highlighted that right now, in the face of the COVID-19 pandemic, these shortfalls in the public health workforce at a time of intense demand have compromised our ability to not only effectively respond to the pandemic, but to maintain the routine essential functions of a health department. So what that means is all the resources have shifted to mitigate the current coronavirus outbreak, which is important, and we want to do that. But the consequences of that are that we are not able to effectively manage other important things that are still impacting individuals and communities on a daily basis right now that we're even seeing, such as maternal and child health, domestic violence, substance abuse. And so what this does is it exacerbates the overall societal impact of the COVID-19 pandemic.
Public health, I'm kind of very interested in the structure of it. How much is national? How much is regional, state, local? The funding of these things, the CMS, the Centers for Medicare and Medicaid Services, reimbursement is really decided at the top of the pyramid at a national level.
Mm-hmm.
But for public health, is that more on a state by state or locality by locality as far as priority of funding for these?
Yeah, so that you're exactly right. At every state has a state public health department that's overseeing it at the state as a whole, but public health itself is really then further decentralized to a local level. And so that's why you have your local or your county health department that's overseeing a lot of the programming and interventions more on that smaller level. But you're exactly right. There are allocations of funds that keep coming down, from the state level to those different local or county health departments.
I would think that would lead to a great variation in the level of the ability of public health response, depending on what part of the country or what state you lived in. I'd imagine quite
Exactly.
a bit. Yeah. Well, so let's talk about the pandemic. Mm-hmm. So this is probably something you, in your education and your experience, I imagine most people involved in public health for decades have looked over their shoulder and think, when is the pandemic coming? We had the SARS and MERS and Ebola. Everybody got hackles up a little bit about it, but then those would kind of die away or really not become contagious, at least in the U.S. And then all of a sudden, the thing we'd always seen movies about was here. And it seemed like there was a widespread, I guess, alert and warning from the public health professionals that something big was coming. And then over a weekend, the whole country, I guess, the politicians were exposed to data that they got it also. And so then we went to the shutdown seven or eight weeks ago. And just on a personal level, when did you have a sense that a big wave was coming and it wasn't just a threat, it was real? Was it when we, in Washington State? That was, for me, that nursing home that suddenly was overwhelmed. And then we thought, oh, my gosh, this is very contagious and could spread quickly. Was there a certain sense that you had that we were in for something big?
Yeah, it's interesting you say that. So on a personal level, I happen to have a sister who lives in Taiwan, and she is a nurse also and a public health practitioner. And she's lived there for 15 years and has really lived through different epidemics that have passed through Asia, and she's really been on the front lines of that. And so if it's interesting because this was hitting China and Taiwan December, maybe even beginning of January. And so I felt like I had a pulse on some, whatever seismic activity. And because she called me, and she knows my background and career, and we're both really interested in disease outbreak and management. And we started having discussions then. And she said, this is coming. This is what's happening in Taiwan. And it's interesting because Taiwan has been touted as having an amazing and quick and timely response to COVID-19. Your listeners could go and do some research. They've done an amazing job of containing the virus. And so I felt like I was getting a little bit of an early peek at what was happening before it even came to Boston and New York and Seattle. And we were seeing right then how quickly and how infectious it was. At that time, even in Taiwan, they had a total lockdown. Everybody was getting access to personal protective equipment in the hospitals because they'd stockpiled it from years before, learnings that they experienced from the SARS outbreak. They were doing contact tracing. People were getting fined if they left their home or weren't wearing a mask. I mean, they had an amazing, concerted, coordinated response to this. And then it was interesting because you started seeing, it coming into the U.S. and global travel was at an all-time high still right up until, the end of February, beginning of March. President Trump had done some lockdown that was somewhat effective in China, but you can read that like in New York City, there were still 3.5 million people that came through New York City from other countries besides China. I mean, we have such a global setup now. And so it wasn't effective in containing the virus. And then we saw it just start, these hot spots emerging. And so it's been, really fascinating from a professional standpoint to watch, and obviously deeply devastating, from a personal standpoint to watch when you see who's being impacted by this. But the lesson learned is, and the lesson learned in all of this is that there is a way to have a meaningful, prepared, coordinated response. There are experts that know how to do that. And I think that we're learning now that maybe we could have acted more quickly.
I know you certainly have deep personal nursing experience in different cultures and different countries throughout the world with all types of different health insurance coverage and healthcare delivery programs. And so I would imagine that the policies behind some of those, just from a clinical, I guess, perspective for you would be interesting, as you mentioned how Taiwan responded, and to compare that with how the public health policy has been enacted in Sweden, which is kind of like, well, we're just going to not lock it down too much and ride with it, from my impression. And, another thing that has kind of surprised me is where we are now, early May. It was pretty clear what needed to be done 2 months ago, which was shut everything down. Now we're not sure how to open up. So there's almost more uncertainty now, the risk of what to do next. And we just have to rely on the data and people who have experience in these things. And it's almost, if not day to day, week to week, as to how quickly we can open up. There was a sense that we'd have a peak and then we'd come down the peak. But it looks like we've gone up and we're at a plateau. And how long is the plateau in terms of, daily things? Well, what role do you see public health nursing playing in the future, moving forward, after all this has happened?
Yeah, I think on the most basic level, some things I would advocate for are just, I think that, we can really shed light and raise awareness on the importance of promoting health and disease prevention first and foremost. I think that this is at the heart of public health, and I think that really paying attention to the science and the data, like you were saying, is important. And where I see the role of public health nursing is like I was saying earlier, being those linkages and translating that knowledge. What does that mean? Like on a very basic level, in my community right now, for people who are not clinical, everybody's told to wear gloves and a mask when they go out. What they're not really taught, though, is how do you make sure you dispose of your gloves properly before you come back in or before you get back into your car from the grocery store. Little things like that are things that I have found myself going over with my family and my community to help them think through, yes, the basics are there. Put your gloves on and your mask, but they're only going to be effective if you dispose of them properly before you touch anything else, your phone, your keys, or anything else before you get into your car. And I think that we are knowledge brokers, and I think that a big part of our role is really taking that data and the science that we know and making it digestible for the people around us. I also think that on a larger level, sort of like what I would say is what I'm thinking about and moving towards is advocating for aid packages at the highest levels of our government to support state and local public health departments and their efforts to continue to monitor and conduct and evaluate public health activities. And I also think we need to really advocate for transparency in the allocation of those funds to our local departments, like we were talking about, to ensure that we're not creating wider disparities within our population by putting all of our efforts into a single response. And that kind of gets into what you were talking about earlier, Jim. You know, as these funds are allocated to different counties, it's important for people at the highest level to really ensure that they're being allocated in a fair way, that we're not widening health disparities in certain communities. And I think lastly, you know, public health nurses can really play a role in recognizing and promoting the importance of strengthening our public health infrastructure by raising awareness of the critical role that we play in ensuring that our communities are living their healthiest and best lives. And so those are a few of the things that I'm thinking about in the midst of this.
You know, Emily, the article you mentioned earlier, and you sent me a link to it, and I read it. It's really fascinating. It's truly a call to action for, as you just mentioned, a few things: increased funding, transparency, training, and really a rebuilding of the public health network that really has been constrained over the last decade, if not longer.
Yes, you're exactly right. And as I mentioned, Joyce Edmonds and some of my colleagues that had written this, they're doing a lot of advocacy work at the American Public Health Association and really trying to get people to think about what can we be doing right now to really improve the public health infrastructure. And it's important, you know, to note all of these things.
Well, unbelievably, we're almost totally out of time, Emily, but I want folks to know how they could find out more about what Day Health Strategies is doing, and should they just go to the website, or what's the best way to find out the work y'all are doing?
Yeah, definitely. You know, you can go check out our website at Day Health Strategies. As you mentioned earlier, we're a healthcare consulting agency, and we really specialize in providing guidance and technical expertise to nonprofits and governments and health systems. And we also really focus on that translating and implementing healthcare policy. And we would love for you to come to our website, or if you're in need of any solutions to problems you may be having, check us out, and we would love to come help you.
And you work with practices, with hospital systems? What type of organizations
we
do you work with?
Yeah, nonprofits, government organizations, state agencies, health systems, hospitals, you name it. We originally started to help implement different facets of the universal coverage that was passed in Massachusetts in 2007. And we've kind of taken off since then. Our founder, Rosemary Day, is an expert on implementing different pieces of the Affordable Care Act legislation. And we've also kind of morphed into doing a lot of health service delivery transformation, so kind of helping businesses become more efficient and effective in what they're doing. So we're a little bit of everything, and we would love to work with you if you're interested.
Well, okay, and that website is DAY, dayhealthstrategies.com. I want to thank our audience for joining this episode of the Tate Chronicles. I offer a special salute to my guest, Emily George of Day Health Strategies. Emily, thanks for coming aboard today, and thanks for your service.
Thanks so much, Jim.
You can find more information on this show's page at healthcarenowradio.com, where you can also find Emily's podcast. And until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.